is Health Technology Assessment, HTA, in Canada. And our presenters will specifically talk about some important topics of interest that the oncology patient organizations learned at the recent annual symposium that's held by the main health technology agency for Canada, called the Canadian Agency for Drugs and Technologies in Health, or CADTH. And if you look at our second slide, you'll see that the theme for the CADTH Symposium this year was Evidence for Everyone, Expanding the Reach of Health Technology Assessment. And we'll be talking about how we experienced this theme and whether we think, in fact, we did learn more about how HTA will be expanded to include everyone, including, of course, patients. So I'll start with a brief introduction to the topic, and then I'm going to be turning to Elizabeth Lai of Lymphoma Canada, who will be speaking about health technology assessment processes and what they value, followed by Sabrina Hanna from Save Your Skin Foundation, who will talk to us about the need for change in the HTA process that she perceived that will impact patient organizations. Then Mona, who you've just met from the Canadian Cancer Survivor Network, will talk about her observations about the patient experience of this symposium. And lastly, I will change hats and become Martina Laya, who works with Myeloma Canada, who couldn't join us today. So I'm presenting her feedback on what's being done internationally on HTA. And then, of course, we'll open the floor up for questions. Please put your questions into the chat box, and we'll answer as many as we can, and we'll be happy to follow up with anyone who doesn't get enough of an answer or we can't get to your question after that. So turning to our next slide, as background, you can see from this slide that there is a division of payment reimbursement systems and who pays for which pharmaceuticals in Canada. Overall, 41.6% of reimbursements are paid through public sector payers and 58.4% through the private sector, divided between 34.5% by private insurers and a very large 23.9% paid by individuals themselves. That's out-of-pocket expenses, and that's a very important gap number for those of us who are interested in access for patients. So if we look at the next slide, you'll see that in order to go through from drug development to the actual access and in the patient's hands or bodies, there is what we think of, at least as patients, as a very complex pathway. And we're not going to be talking about all the sections of this pathway today, but you'll see that the health technology assessment part is right in the middle, and it should be. It's one of the very pivotal processes that impact access for patients for drugs. So if we move on then, you'll see that on the next slide, we're slide number 5. Health Canada is the first step after the drug development process. Now, the drug development process can take 7 years or more from the time an idea comes into the researcher's head until we see it reach Health Canada for consideration. And then Health Canada answers the question as to whether, looking at those trial data that they receive, is the drug or biologic, or even medical devices, but those aren't of interest to us here today, are safe and effective and of good manufacturing practices, and therefore should be allowed to be sold in Canada. If the manufacturer is permitted to sell it, if Health Canada answers that question yes, they continue to monitor for post-approval for ongoing safety and effectiveness, sometimes called real-world evidence, and we're going to be talking a lot about that in relation to CADTH as well. So then let's move to the next where we actually look at CADTH. CADTH is a federal, provincial, territorial health technology assessment body. It has two primary reimbursement recommendation pathways. One is called Common Drug Review for non-cancer drugs, and it considers clinical economic evidence, and I would say finally, that's my editorial, patient input. The other stream is the Pan-Canadian Oncology Drug Review Program. This is for the oncology drugs only. It considers clinical, economic, as well as patient input and ease of implementation equally as its deliberative framework. It decides, both of them actually look at the value of the drug relative to others and relative to opportunity costs of funding this drug versus other drugs. It's more complicated than that, and they have some very complex formulae that they use, including an analysis of what's called quality of life years lost, or QALYs, as you may hear the term. This organization makes a recommendation to the provincial and territorial health ministries as to whether they should in fact consider, because it's only a recommendation, reimbursing these drugs through their public reimbursement system. They may recommend that they do so with conditions or criteria, including often price reduction before it's agreed to, or they may say no, don't reimburse this in the public system. Now, I said this was a major health technology assessment process in Canada because the other concurrent process is in Quebec, and it's called INEST. We won't be getting into details about that. It wasn't their symposium, so we're reporting back on the symposium we attended. So what did we learn then of interest to patients and hopefully the other participants on this webinar? And for that, I turn over to Elizabeth Lai.
Thanks, Louise. So I feel like I should declare that I am relatively new to the HTA process and the big machine that is CADTH, certainly a rookie in this group of patient advocates. Although I do feel like I've been through a pretty rigorous initiation recently with all of the patient submissions we prepared for PCODER. But this year's symposium was my first. So maybe that's why I get to speak first, so that my colleagues have an opportunity to correct all of my somewhat naive assessments and interpretations of what CADTH and the HTA process does indeed value. But I will keep my fingers crossed that I'm not too far off the mark. And yeah, I'll get started. So Matt, you can switch. There we go. So as Louise mentioned, this year's symposium was all about evidence, different types of evidence, varied methods for gathering, synthesizing, evaluating, interpreting all of this evidence. And I was really impressed with the scope of expertise and the breadth of topics that were covered over the course of 3 days. That said, I think there are definitely two types of evidence or categories of evidence that were most often discussed, and obviously common to all HTAs and likely preferentially valued in all cases, and these are obviously namely clinical and economic evidence. And while we would all hope, I think, and expect that the clinical evidence and the clinical benefits to patients would carry the most weight, my very limited experience with PCODER certainly indicates that often the economic evidence appears at least to be the limiting factor when it comes to recommending funding for new health interventions. The main purpose of conducting an HTA obviously is to inform policy and decision making. In the case of our public healthcare system, whether new healthcare interventions should be public or funded by the provinces. So therefore, I guess it shouldn't really come as a surprise that the costs associated with new techs and specifically new drugs appear to carry much greater weight in so many HTAs than other factors do. What seemed a lot less clear throughout the symposium, though, was how much other factors, and specifically patient input, are valued as evidence. We've been told in the past that the better patient submission, the better the chances are that it will impact an HTA recommendation for funding. And there were certainly a few experts that spoke to the need for more meaningful incorporation of patient feedback and bringing the patient, caregiver, and community experience into the process in a much more meaningful way. And I think we can all agree that there's definitely a need for a more systematic approach to collecting and analyzing this type of qualitative evidence that we as patient groups bring to the process. But there didn't appear to be much interest, or there doesn't appear to be much interest on the part of CADTH to, unfortunately, to facilitate this or support this in the way that they do with other types of evidence. So I think as patients and patient groups, we're still left questioning, what our role as patient advocates are in the HTA process, and whether our input really is respected and valued. We're certainly not going to throw in the towel, and we're all obviously committed to continuing our work. But we're just not as far along, certainly in terms of value and respect, as we would have hoped, I think, at this point. So the next slide. So one area that does appear to be receiving some attention and also some action from CADTH is ethics evaluations in HTA. I was really fortunate, I think, to attend a workshop that really dug into all the components of ethics evaluations, including current barriers and limitations to implementing them in the evaluation process. And CADTH has started incorporating systematic ethics evaluations into the HTA process, and I think this is being spearheaded by Ken Bond, the Director of Strategic Initiatives at CADTH, who previously at the University of Alberta and the Institute of Health Economics worked extensively on conducting and improving ethics analyses in HTA. So I think at least they've got the right person at the helm. And I do want to, I did sort of want to point out an area that was discussed by one of the presenters was the identification of values on which to base our ethical evaluations. And there is, of course, a very long list, but one place to start is with the Canada Health Act. And I chose to highlight this today because, while we all know it exists, I don't know that its main principles are always top of mind for those making policy decisions, especially during the HTA process. And, namely that all publicly funded health programs should be publicly administered, comprehensive, universal, portable, and accessible. And, and really should be the foundation of, all ethical evaluations. And this is obviously just one of many sets of values that can be used in the evaluation process, but I think it's one that we shouldn't forget about. And internationally, it's well recognized that by identifying and analyzing ethical issues, the HTA process can support better informed, value-sensitive decisions. Unfortunately, in contrast to other parts of HTA, such as outcomes and safety reviews and economic analysis, there's little agreement on how to incorporate ethics into HTA, and there's no established process currently. So CADTH is engaging leaders in this area to develop a formal framework, and they have been training ethicists in the HTA process and have started engaging them as well in evaluation processes on a case-by-case basis. So they are moving forward with this, and I'm hopeful that it will continue. Next slide. So more and more and more evidence really was the theme of this year's symposium. Just about every type of evidence you could imagine was discussed, and I think there's growing acknowledgement among thought leaders, academics, and as well as decision makers at CADTH that the traditional HTA methods don't necessarily reflect the complexity of new health interventions, nor do they consider successful adoption or implementation in some cases. And some examples in oncology that come to mind are oral targeted therapies and some of the newer immuno-oncology treatments that have very different outcomes and resource utilization than traditional chemotherapies. So we really do need a better way to evaluate these and other factors going forward, and there were presentations and panel discussions about numerous other types of evidence and evidence gathering and analysis, and I've listed some of these here. I won't go into detail because I don't want to take up more than my time, but while I think there's a genuine interest on the part of CADTH to incorporate other forms of evidence, at this point I don't think there's a clear understanding about which evidence is appropriate for each new technology, how and when, and to what extent different types of evidence should be used or incorporated into HTA. This is definitely an area that will require a lot of thought, work, and and consultation on the part of CADTH in order to evolve really to a more dynamic process that addresses the specific evidence need of each new intervention. So next slide. Before I pass over the mic to Sabrina, I do want to highlight a couple of projects or initiatives that CADTH has undertaken to engage external stakeholders recently, including patient advocacy groups. The first is the update of the guidelines for economic evaluation of HTA in Canada. It's certainly a large undertaking, to be sure, I imagine. I wouldn't want to be involved in that, but at that level. But a number of us as patient advocates did get together this year to add our voice to the recommendations for changes and updates to these guidelines. Louise was really instrumental in bringing us together with a health economist who has experience with HTA evaluation, who gave us a crash course, really, Health Economics 101 and the HTA, a really great overview of the HTA economic evaluation framework to enable us to participate in a meaningful way in submitting feedback about the guidelines and how we think they can be improved and really made more accessible to patients and the broader public. And I did attend the very early breakfast meeting at the symposium where CADTH gave us a bit of an update on this process, and hopefully we will have some concrete documents in the near future to review, hopefully in the coming months. And another initiative that PCODER is piloting is the involvement of clinicians as hopefully as valued external stakeholders in a more formalized process to provide input for oncology drugs under review. And obviously clinicians have always been involved in one way or another in preparing the clinical guidance reports and on the expert review committees. But I think it's been really frustrating for many who have firsthand experience with new technologies and specifically in oncology with new drugs under review, that they haven't had been able to provide input in a formal capacity. Much like the current patient input process, CADTH has drawn up a template for physician input that will allow expert clinicians to formally now submit experience and their expertise with regards to the drug under review. I think in the past oncologists have been frustrated because they've more informally submitted letters regarding new drug therapies and really heard nothing back or received a form letter, and no one really knew what happened with this information, and how it was collected and evaluated. So we're excited that this is happening, and the oncologists I've spoken with are certainly also excited and more than willing to participate, and hopeful, a little skeptical, but also hopeful that this is an indication that their expert input will be valued and incorporated in the evaluation process in a much more meaningful way than it has been in the past. So with that, I will turn it over to Sabrina.
Thank you, Mona and Louise, for having me today. So I'm going to talk about the need for change in HTA, and the theme for this year's symposium was Evidence for Everyone, expanding the reach of health technology assessment, or what does this mean and who is everyone? On the symposium page, the descriptive paragraph says, initially established as a tool for policymakers, health technology assessment now supports a much broader range of decision makers. Everyone, whether technology developers in academic settings and industry, patients, clinicians, regional health authority and hospital administrators, or private sector insurers, can benefit from the evidence produced by HTA bodies. Because HTA wasn't originally designed with these stakeholders in mind, its processes and outputs need to change to make it easier for clinicians, patients, and other key stakeholders to integrate evidence into their decision making. And Matt, if you want to just slide through one more. We heard from multiple panelists keywords like real-world evidence, evidence to action, evidence-informed decision-making, and quantitative versus qualitative data. When it comes to evidence, are we as patients, decision-makers, industry, payers, policymakers, regulatory bodies thinking about evidence in the same way? And what does evidence mean to the different stakeholders? How is CADTH integrating this evidence into their processes and outputs? How is this information being provided and by whom, and what value do they hold? They raise an interesting question. Do the processes and outputs need to change? And the evidence, certainly from what we heard at this year's symposium, says yes. There is a most definite need for change in the design of processes and outputs within CADTH in order to meet the needs of all its stakeholders so that the evidence works for everyone. If we look at the next slide. Qualitative data gives a voice to the science. It provides a bigger picture of the treatment beyond safety and efficacy. It's a means of providing evidence outside of the scientific realm and into the real world. This is the type of data that patient submissions often contain. What are the unmet needs? What are the experiences of the current treatment? And what is it like to live with the medical condition? While quantitative data will tell us that nausea is a side effect, the qualitative data will tell us that the nausea is so bad that the patient is unable to leave the house. And this is important information for decision makers, for patients, but also for payers and industry. Because the patient experience is subjective, it's also difficult to create measures on these experiences or quality of life values. Patient groups need to be able to translate qualitative information into quantitative data in a way that is meaningful to the experts who are reviewing the information and making the reimbursement decisions. But how do patient groups implement the qualitative data in a way that gives patient input more meaning? On the next slide, we heard at the symposium that patient groups sometimes do a disservice to their patient population with the submissions. How are we as patients and patient groups interpreting the evidence? In order to provide evidence from the patient perspective that is valuable and relevant, patient groups need to be educated by these experts on what qualitative information is relevant and how to translate it. CADTH should be clearer about the information they are looking for from patient groups by providing a template or guidelines and educating patients on what qualitative information they are interested in and how to present it in a format that is informative and appropriate. We heard that patient input cannot be objective because funding comes from our industry partners. If this is a concern for CADTH, then independent and objective resources should be provided to allow patient groups to develop submissions that are professional and relevant to the patient experience. In order to provide a better picture of what's going on, there's a need for scientific literacy from a patient perspective to translate the quality of life values and broader societal values relative to patient values into a formula that can be recognized scientifically. Moving on. We heard at the symposium that patient input could not influence experts to make different decisions, but better decisions. But what does this mean, and what is the value of the patient submissions if quality of life information, patient experience, and patient values provided through input would play no role in swaying decision made by the expert committee? There's the gap between theory and practice in our HTA system. HTAs say they want to have patient input, however there's a lack of meaningful patient engagement or accredited value to the information provided by patients. If this is the case, are we all thinking about evidence the same way? How can change be affected into something that creates more meaningful patient engagement? Looking at the next slide. Is there a process that validates real-world evidence and creates measures or a formula for quality of life data? How do we validate real-world evidence? The quantitative data says that nausea is a side effect. Well, what does it mean to have nausea? Is a patient stuck in the house all day due to nausea, or is nausea occurring in minimal levels? If the experts are unable to recognize the value of the qualitative data, then there's an issue in knowledge translation from the patient to the experts and the decision makers. We heard several comments regarding the objectivity of patient groups. There exists an important need to educate professionals, experts, and public representatives who sit on these committees on what the role of the patient groups is in the healthcare system and their commitment to patients. Another need for change, patient centricity. The 2016 CADTH Symposium met all 5 of the patients included charters clauses. The patients included charter provides conference organizers with the means of demonstrating that their events are committed to incorporating the experience of patients who are experts in living with their condition while ensuring they are neither excluded nor exploited. And the patient charter clauses are patients or caregivers actively participate in the design and planning. Patients and caregivers attend and participate. Travel accommodation expenses are paid in full in advance. Scholarships are provided. The disability requirements of participants are accommodated, and access for virtual participants is facilitated. I think, Matt, there's a slide for that. We all know that healthcare faces huge challenges, budget cuts, increasing demand, and a shortage of skilled personnel. To help find solutions to this, conferences are set up, meetings are planned, and committees are built to discuss the changes needed. But most of these discussions happen without the people they are all about, the patients. It is not only important to make sure that patients are invited to conferences, but also that they are able to participate in a meaningful way in the decision-making process that has a significant impact in their day-to-day. Next slide. We heard that patients could not understand the, I think it's a few slides forward. Sorry about that. Can we go back to the patient centricity? We heard that patients could not understand the data. The patient groups only see HTA as a barrier to access to drugs, and the patient groups are shills to industry. There's a lot of talk around patient centricity, but very little action. A shift in the perception needs to happen in order for patients to really be included. Another change is efficient HTA in real time. Health technology assessment refers to the systemic evaluation of properties, effects, and/or impacts of health technology. It is a multidisciplinary process to evaluate the social, economic, organizational, and ethical issues of a health intervention or health technology. In essence, HTA is the interface of science and policy. Currently in Canada, there are not enough health economists and health technology assessment professionals. We are facing a situation in which the evidence outstrips our HTA capacity. How do we continue to evolve HTA with time delays, budget constraints, and a lack of resources? We heard how many practicing physicians and clinicians do not understand HTA or are even aware of it. If physicians don't understand HTA and they're not informed, how can they be part of the process? Next slide. In order to change, we need to join the digital age. Information management, including talking to each other, digital records, data management effectiveness. A good practice from the U.S. Department of Veterans Affairs where Hep C drugs that are expensive and increasing were made available and costs were managed through effective data management system. Collaboration in an effective way, share everything, hide nothing, and adapt often. Improvement of transparency and communication, identify language to communicate effectively to audiences. Take HTA, already delivered, and adapt to our setting, whether that's Quebec or Newfoundland or Alberta. Currently, too many processes exist, causing redundancy with Health Canada, CADTH, and the NES in Quebec, and now with the introduction of peer drug watch programs. Is all this really necessary? Consult with people who benefit from and use the work of HTA professionals, including decision makers, patients, and clinicians. Establish patient-citizen councils and check methods and decision-making framework with them. Next slide. We have a small picture mind frame instead of looking at the larger picture. For example, Ontario and the Atlantic provinces are not covering the cost of take-home oral oncology medications, while other provinces and territories do, citing cost as one of the reasons. By doing this, they are not recognizing the cost savings to hospitals, emergency rooms, and employers. Next slide. We always hear about the cost of drugs, but no one ever talks about the cost of implementing all these separate processes and outputs or the administrative costs of the healthcare system. A more efficient system takes into consideration the economic benefits of introducing new and innovative medicines into the healthcare system, as well as the healthcare savings that patient groups bring to the system by helping patients navigate the system and unburdening our already overburdened medical professionals. At the moment, HTA is only used to determine the value of the 16% of our healthcare budget that covers drugs. Why do we not expand HTA to measure the value we're getting from the other 84% of the healthcare system? So finally, yes, there is a need for change. And what will HTA look like in 2020? And with that, Mona, it's off to you.
Thank you, Martine. I'm going to be covering a little bit of the same ground, but I think that's only indicative of the take that patients, all of us, had at the CADTH conference. Next slide. I think we're, all of us noticed very much the patient included checkmark or branding that was used quite extensively throughout the promotional material for the symposium. This was told to us that this was a certification that they had really achieved the patients included requirements. And the evidence is that I have looked this up, and several other people have as well, that this is a self-certification which any organization can use, providing they meet criteria listed on the www Patients Included org website. That means there was no process, there was no presenting of evidence about how patients were included and to what extent presented to anybody at all. Somebody at CADTH read the website, decided that they met all the criteria, and downloaded the logo, Patients Included. I find that embarrassing. What was missing? Very few patients were involved in panels. Very few were given scholarships to attend. The financial support that was available had to be divided between the students who were presenting or had posters and who are studying in appropriate disciplines, and patients. And it was not clear what patients or patient groups were participating in planning the symposium. And as the Patients Included website says, this would include that patients were involved in choosing themes, topics, and speakers, and in presenting. I don't know if any patients were involved in any of that, because there was no recognition or thanks in the program for any participation by patients. So this struck a lot of us very strongly, because we've been in patient groups, and myself, I've been in patient groups for years and years, and so have many of the other people on this webinar, and really I'd never heard of this good housekeeping symbol of patient inclusion. And it really, it's just a self-certification which you can download. So CADTH, really. Next slide. I was struck particularly, one of my colleagues earlier in this webinar said that this was her first attendance at the CADTH Symposium. I have attended 3, and I'm really, I'm disappointed to say that I'm seeing the same things now this year as more and more other organizations are being realistic about patient inclusion and patient participation, that CADTH is still obsessing about certain things, and that CADTH staff and CADTH presenters were really expressing some of the same things I've been hearing for years now. And this is strong belief that patient groups are in conflict of interest if they receive pharmaceutical company funding. I think some of the researchers who worked at hospitals there would, their hospitals receive pharmaceutical company funding. There is a disdain for patients and patient groups that use SurveyMonkey or similar free or economical web-based tools to survey patients. They think this is not professional. They believe that patient participation is a risk. Patients will be uninformed, will belabor our own experience, will disrupt professional decision-making. The belief that patient input for drug reviews is suspect because it's not seen as professional. Lived experience is not seen as valid. And patient groups are questioned about their representativity and who they report to, whereas this is never questioned about the medical and academic experts on the panel. We, for instance, reported through our newsletter about this conference to the 8,400 people who have signed up for the Canadian Cancer Survivor Network e-letter. So as far as reporting to, there you go. Next slide. I'm reproducing CADTH's own slide, own chart here. And CADTH, it's a bit scary. It's a conservative bureaucracy, and for instance, this is the CADTH common drug review process, and I couldn't get it all on one. We'll have 2 slides in a minute, but if you count down to the 5th box in the middle, and you'll see and patient input sent to. Now, that's where patients are mentioned in the CADTH common drug review. And as my previous colleague mentioned that maybe there could be economies found in the way some of the things are being done at CADTH and other parts of the health system in Canada, but I even question how many things do we need to duplicate, how many drug assessment and technology assessments do we need to duplicate that are already done in the United States, sometimes years earlier, and in Europe. I know that there will be differences in how the evaluation are undertaken and what is evaluated, but I think pretty well that there's plenty of overlap there, and that this kind of money should not have to be really sent out and spent this way. Next slide, please. There, I don't want to scare you, but that's the rest of the slide that describes to us the CADTH Common Drug Review. So I don't have any more to say to that. You can look it up on their website. They may have more explanation. What's missing? Transparency about CADTH itself is funded. CADTH is very opinionated about the funding of the patient groups, but what is CADTH funding? CADTH is federal and I guess provincial funding, but I understood that it was about $25 million to $40 million. I'm not sure of the amount because I could not find a financial statement or an audited statement on the CADTH website, and maybe I just didn't find it, and maybe it isn't there. But we need some transparency about CADTH itself, so that we can form our own opinions about biases that CADTH may have. And if they're solely government funded, they don't really have any independent source of funding. And the governments for the last quite a number of years, their take on this has been that we have to stop spending this kind of money. It's getting to be an increasing part of the health system costs, the drugs that we need, and that this is that's been the bias of the funders of CADTH. So what effect does this have on CADTH deliberations and CADTH policies? Cut. And really patients, I think, are legitimately should be able to look at that bias and make up their minds about it. What's missing is a genuine understanding and respect for patient participation. I've seen examples in the States where patients are welcomed, heard, and who are trained and who are sought to participate in reviews of drugs and funding for research. We're missing patient pathways on the CADTH website. It's very difficult to find out who the patient representatives are, where they exist, how they're picked, and for how long a term. I know that from 3 years ago through to the current CADTH Symposium, I'm seeing some of the same patients that were there, and I'm hearing them on panels. I think that we have a legitimate concern about dangers of patients being co-opted because they're starting to talk just like CADTH staff, and that's not all bad, but at the same time we need to have some open door to other than house patients. We're missing training. We're only hearing about training for patients so we can be more professional, so we can understand more, so our presentations will be better received. But how about training the researchers and academic experts on the value of patient input and lived experience? I think that training idea goes both ways. What's missing is critical mass. We have patients on there, but they're the patient. Some of us know who they are, and they've been the same patients for a while. We need more patients, perhaps a panel of patient experts to be called upon in turn to serve, a quarter of the year and then come back 2 years later with updated training. But I think a bigger panel of patient experts, and I think they're certainly available in Canada. And we need to do away with literature search as a source of patient experiences and work with real patients. I sat through an example of patient opinion and patient participation in CADTH that was strictly taken from reviews which cost thousands and thousands of dollars of literature that may have had 1 or 2 patients mentioned in them, and this was extracted from these literature and presented as a whole list of a patient experience. I think that's not valid. I think that we need to work with real patients. We need to know that the patient experience is current and valid. And I think there's ways of doing that. What's missing from the CADTH Symposium itself is dedicated ways for patients to track their way through. For instance, patient tables at meals and adjacent spaces that are identified for patients, so patients can share experiences and comments on what's going on. And I think it would give some patients more ability to speak up and to participate more. And serious funding to allow more patients to attend. Really part of another pot that existed before isn't really the best thing. So that's my experience as someone who's jaded after 3 years of CADTH symposiums. And I'm going to turn it over to you, Louise, now.
Thank you. So far you've heard a lot about areas that require change from the patient perspective and enhancements to our major HTA process in Canada. But I don't want to leave this with you thinking that we don't think some things are working really well and that some things are not improving. Because we do. We certainly, as the oncology patient groups, when we get together, we think PCODER generally works very well for both oncology patients and groups, and we're very pleased to have seen that so far the integration into CADTH has not changed the culture of PCODER, and we'll continue to watch that, but we're cautiously optimistic. We think it's wonderful, as Elizabeth mentioned, that we're now allowing for oncologist submissions. I think that's a very big step forward, and it definitely shows continuous improvement, as does the creation of the Patient Liaison Forum, which is really morphing into quite an interesting and exciting group, and you'll hear more, I'm sure, about changes, even further enhancements to that. Having said that, I now become Martina Elias and present her slides about international best practices. So if we turn to the first of her slides, one thing that is clear, became clear to us at the symposium, is that the issues we have with HTA in Canada are shared globally. And the same questions are being asked around the world in many countries. Can regulatory decision makers change their decision-making paradigm to include a more robust understanding of qualitative evidence, of real-world data, and of patient values? Can industry adapt to the needs for information and research design and creative pricing models that numerous stakeholders are demanding, including regulators, HTA bodies, clinicians, and patients? Can we find a reimbursement model that recognizes budgetary issues, sustainability, research data, real-world data, clinician expertise and experience, and individual patient choice? Put another way, can we manage the continuum of care from bench to access in a smooth, efficient way? So the next slide shows us that an example that Martina and I know from our own home province, where she certainly noted the need for enhancement in patient engagement. It relates to the processes at Cancer Care Ontario, the agency in Ontario that's responsible for taking the lead in cancer policy, including reimbursements. And there were presentations from CCO at the symposium talking about its intention to use real-world data, for instance, to address payer needs with the potential to validate funding decisions. It also expressed a commitment to expand the use of real-world data to inform decision-making by collaborating with other cancer partners. And it invited the audience to give it advice about how to involve others in this real-world data gathering, but they actually did not mention explicitly the inclusion of patient voices as one of its key partners. And a question for a lot of us in the patient community is, how can we gather real-world evidence, real-world evidence, and interpret it properly without that meaningful partnership at the core of its work? So where are the patient voices in all of this? But if we turn to the next slide, you'll see that there are some good, we don't have to reinvent the wheel here in Canada, nor should we. There are some best practices internationally, for instance, in the area of collecting real-world data that involve patients meaningfully. And one example that Martine brought to us was the Get Real project that the European Union is involved in. So it's a data collection process. It aims to bring together numerous stakeholders, including healthcare decision makers, academics, clinicians, industry, and patients, to propose innovative trial design, to assess the value of information, to propose and test new HTA approaches, to create new decision-making supports and tools, and to share deliverables with each other. And on the next slide, you'll see another approach that the EU is using called Adapt Smart, and it's a platform that helps to ensure access to beneficial drugs for the right patient at the earliest appropriate time in the lifespan of the product. We can also learn from the list of innovative reimbursement schemes that are listed on the next slide. So you'll see that to date, if you look to the right of your screen, there are a list of innovative reimbursement schemes that could be used. We in Canada have only used a few of the non-outcomes-based ones, but we really must become creative and expand, since as the cartoon on the left shows you, we're not likely to have a drug-free world anytime soon. So as the next slide shows, the bottom line that we've learned from the international best practices is that collaboration is the key. And the EU seems to be striving for that, and it seems to be getting a little closer at least than we are. And you'll see here that this slide defines how broad collaboration can shape the gathering and analysis of real-world data for the better. And the next slide shows us that if we all pull together, it's much easier to push that rock uphill than if we're working against each other. So to finish, a few minutes later than I expected, but not too many, on the next slide you'll see that if we have whetted your appetite for health technology assessment and the symposium content that we attended, please go to our website, the CCSN website that's shown here, where you will see a full group report back from the folks on this call and some people who couldn't attend today with recommendations. And so in closing, I really want to thank our great and really modest, unnecessarily modest panel of Elizabeth, Sabrina, Mona, and Martine in absentia. And I really hope that I say this to the patient groups on this call, please, we hope to see you join us at the CADTH Symposium next year. And in the meantime, we'd love to see as many of you as possible at the PharmaCare Roundtable that the oncology and related mental health groups are holding on June 1st. We'd be glad to give you more information about that. So we promised you 15 minutes. I'm sorry it's only 10, but I hope that the information we provided has been worth the time. I don't see any questions that have been written, but please, if you have questions, would you write them in, and we will be more than pleased to answer them. If not, you might have to listen to us for longer. Which may be bad, may be good. So don't hesitate if you have any questions. I don't hear any. I don't see any. Then I'm going to put one, if I may, then to the panel.
Louise, do you have a question that you want to ask?
Yes, shall I ask?
Yes, please.
If if you were to sum up a very concrete, practical, short-term thing that CADTH can do that would really enhance the patient's experience of this symposium, what would you suggest?
Do you want to start a round circle? Liz, do you have an answer for that?
Well, I mean, I think you spoke to this, Mona, but I would say really just involving more patients in the panel discussions and the presentations would really go a long way to, you know, giving patients a voice and certainly adding value, the patient's, you know, patient value to the symposium.
Sabrina?
I actually would have said the same, but because Liz said it all, I'm going to go with something else. But I think that if they, you know, they're not really happy with the patient submissions or whatever it is, then I think that they need to give us more concrete actionable items or deliverables that we can work with, that they can give us at the symposium that we can take away and do better patient submissions.
Okay, Mona?
Yes, I think that following the, you know, my presentation, I think is clear. They have to be more genuinely welcoming patients groups, stop putting us down with all of these obsessions they have, and provide ways for patients to meet together in a group at the symposium. I want to let you know, Louise, that questions are coming in, so I'm going to read them to you.
Could you, because I'm seeing them on my screen.
Okay, Louise. So, this is just a thank you. Somebody said excellent summaries, well done. They wouldn't. Somebody else said he wouldn't mind listening to us for far longer. Great work. It says, where will we find further info on the June symposium? It's true, Louise, you just mentioned June 1st. Can you be more specific about that?
Sure. First of all, I'd like to thank the people I paid for those thank yous. I'll send you your checks shortly. On June 1st, the oncology groups across Canada and related mental health groups, because we see those as such profound comorbidities, are going to be meeting in Toronto at Sunnybrook Estates. I would love to have representation from every single oncology patient group across the country. I do have a little bit of limited funding to help a few people get here from afar. And even if you can't come physically, please let me know of your interest. We're really working at getting some process to get you in electronically in some way so that you can be involved. So please contact me. I will be glad. CCAC has put out the has put a notice on their website with the details for us. It's very kind of them. And, or CCAC. Sorry, CCAN. I don't know if CACC has or not, but CCAN has. You can certainly look at their website as well. But if you just contact me at louise.binder@rogers.com, as you generally do, I will make sure that you get all the information you need. We'd love to see you there.
And perhaps, Louise, we could put a few words about that on the CCSN website. Next question is from Stacy, and it's asking, will you be asking CADTH, and in brackets CDR and PCODER, to form some kind of measurement of the impact of the patient input? Good question. Over to you, Louise.
Absolutely. I think it goes without saying that we really want to see a rich training program going both ways. It's not a one-way training program about how to work with patient submissions part of the process, and certainly an evaluation and monitoring of the impact of that and how it's being used has got to be part of one of the outcomes from that training. Absolutely.
The last question, or a bit of a statement, or it's a question. What do you think about asking for the patient leaders, the liaison forum, to be able to audit or sit at and observe an HTA expert meeting. It might be eye-opening. You could see how the patient input is deliberated in the context of economic and clinical and other ethical, etc. That's from Bill. Louise?
Yeah, well, I'd love to hear from what do Elizabeth and Sabrina think about that?
I think it's a great idea. I mean, I've certainly been given some insight from you know, people who have been involved in the expert review committees in the past about what happens behind closed doors, you know, which is somewhat comforting, you know, that our voices are heard and that patients are involved in the expert review committees. But it would be great to be able to sit in and experience it firsthand.
Sabrina?
Yeah, and it would definitely be eye-opening. And as I mentioned in my summary, I think that it would provide us with a better picture of what kind of information these experts are looking for in the patient submissions.
And so Martine says that she agrees with that completely. She isn't here because she's actually working on 5 P-coder submissions today, believe it or not. That's what she's doing. And I'm sure that she would say that being able to really see this in action in real life and how it plays out in the conversations about these reviews would help us all. And I think it would be wonderful if we could have the opportunity as those who develop these submissions to see that. Absolutely. Louise agrees, and Louise agrees with Martine.
I think we all do. We are coming to the end of our time, and so I'm going to do some wrap-up. First of all, I want to thank all of our expert panelists for today. This involved, you know, attending the symposium and then writing it up and now preparing for a webinar on this. And I think everyone's done a huge amount of work, and really thank you very much for that detailed, thought-provoking material. The webinar will be available online tomorrow. There will be a full video on YouTube as well as slides which will be available on our SlideShare account. I'm just going to repeat that. Okay, the noise is gone. Available online tomorrow means at the CCSN. If you go right on our front page, you'll see this whole webinar there, and you can click on it and listen to it again or show it to a colleague who could not attend. YouTube you can find, and SlideShare account. It'll all be links to that from our front page of our website. Links to everyone who registered will be sent out to you tomorrow afternoon. So you will get an automatic link in your email if you had registered for this webinar. We hope you all have a wonderful afternoon. Thank you again, Novartis, for your support of today's webinar. And thank you, panelists, again. And good afternoon, everyone. Thank you for attending.